about hyperphosphatemia, and I hope that you ask him frequent questions about them.
Thanks, Professor Ahmed. Thanks, Professor Hussein, for introducing me. And it's my pleasure to be here today with you. And I'll take a chance to welcome you all from different African countries in our country. Hoping you a very memorized times and beneficial, fruitful course. So my title today is Hyperphosphatemia Management in Chronic Kidney Disease. So I'd like to start by highlighting some checkpoints and headlines for my lecture, starting by a brief introduction, then talking about physiology of phosphorus absorption and excretion, and then jumping to the epidemiology to get the extent of the problem and the dimension of the difficulty of controlling the hyperphosphatemia in chronic kidney disease. And this will highlight why we are discussing hyperphosphatemia and try to treat it in the ideal way. And then I'll jump to the practical issues by how to diagnose and in view of the different guidelines in different situations, starting by chronic kidney disease and dialysis. And I'll end up by some slides about the recent and future management of hyperphosphatemia. In a normal level, from 2.5 to 4.5 milligram per deciliter, the phosphorus accounts for 1.1% of the whole body weight. This makes it the second most abundant mineral in our body after calcium. And this importance comes from its role in different biological activities, starting with skeletal development, cell membrane phospholipids components, as a cell membrane phospholipid component, cell signaling, and its function in the platelet aggregation and energy transfer in the mitochondrial metabolism, and it's one of the most important components of the DNA and RNA inside the nucleus. Total body store is about 700 grams, and as I said, it accounts for 1.1% of the total body weight. 85% of this total body store of phosphorus are in the bone, accounts for 85% of the phosphorus, and the remaining 15% are mainly intracellular. 14% of those 15% are intracellular, and only 1% is extracellular, dividing in 70% organic form and 30% of inorganic form. Of those 30%, 15% are protein bound and other are bound to sodium, magnesium, and calcium. And this accounts for 0.14% of the total body phosphorus. In an average diet, the phosphorus ranging from 1 gram to 1.4 gram per day, and it's absorbed mainly in inorganic form. 100% of the inorganic phosphorus ingested should be absorbed, and 40 to 60% of the organic phosphorus will be absorbed. The phosphorus absorbed over the whole segments of intestine. The phosphorus got absorbed over all segments of intestine through a transporter called sodium phosphorus cotransporter 2B, NBT2B, which is stimulated by vitamin D. Excretion mainly through kidney, so 70% of the body phosphorus is excreted through the kidney and only 30% through fecal excretion. Increasing excretion by down-regulating sodium phosphorus cotransporter 2A and C, which is stimulated by parathormone. There is a wide range of causes for hyperphosphatemia, starting by some metabolic derangements like lactic acidosis, chronic respiratory alkalosis, and some hormonal disturbances like pseudohypoparathyroidism and hypoparathyroidism, Also, some drugs accounts for causing hyperphosphatemia. But we will concentrate on this track, which due to kidney injury or a renal failure, either acute or chronic, which reduce the renal phosphorus excretion, end up by causing hyperphosphatemia. To delineate this course, we will discuss at the beginning the normal renal function, phosphorus excretion in normal renal function. So as you can see, the relative phosphorus is about 900 milligrams, and 70% 600 milligrams is secreted through the kidney, and the other are exchanging between the bone to 150 milligrams, and the other account for the fecal excretion. Anyhow, at the end, the phosphorus concentration are balanced in normal renal function. In chronic kidney disease, the decreased rate of deposition of the phosphorus on the bone and excretion by the kidney will end up by having cumulative increase in calcium in the serum phosphorus level, like by 100 positive serum phosphorus level, which end up by having positive phosphorus balance. This problem is not a rare problem in chronic kidney disease, and as we can see, it started as early as stage 3A in chronic kidney disease stages. So at the beginning of stage 3, the phosphorus started to be retained in the body and build up a high phosphorus level. This slide shows the main player in controlling in bone turnover and controlling the phosphorus level, starting by FGF23 and its pleiotropic effects, and osteocalcine, osteosclerosis, and those are controlled also by parathormone level, and phosphorus is one of the main players of bone turnover. This slide shows the recent publication show when those main players are start to be disturbed during the course of chronic kidney disease. And we can easily appreciate here at the beginning, at the stage 2, the first thing that starts to be out of normal range is the fibroblast growth factor 23, and it starts to get out of the normal range as early stages of stage 2 chronic kidney disease, followed by phosphorus starts to increase but kept in the normal range at the beginning of stage 3A, and start to get out of range more than 5.5 milligram per deciliter at the beginning of stage 4. And as I said, it is not a rare disease, it is not a rare disturbance in chronic and hemodialysis patient, and this data from the DOPSA study recently accessed in the last month showed that about 10% of patients are having serum phosphorus level more than 7 milligrams per deciliter, and about 33% having serum phosphorus level more than 5.5 milligrams per deciliter. And if we accommodate the 15 to 20% of patients who have serum phosphorus level from 5 to 5.5 milligrams per deciliter, we will have like more than 60% of our patients are increased risk to cardiovascular disease. Again, this diagram from the DOPSA study, and if we look to the last part, it shows up like 36% of the patient have serum phosphorus level more than 5.5 milligrams per deciliter, and another 31% have serum phosphorus level more than 4.6 milligrams per deciliter. It means that about 66% of patients on hemodialysis having serum phosphorus level more than 5.6 milligrams per deciliter. So this is the epidemiology of the problem, and as I said, majority of patients are exposed to have uncontrolled phosphorus level. So why hyperphosphatemia is important? As we all know, the cardiovascular disease is the main killer in chronic kidney disease patients. So this diagram shows that the impact of chronic kidney disease and phosphorus retention in increasing the FGF23 and decreasing the closure factor accompanied by hyperphosphatemia, this all will end up by endothelial dysfunction and calcification, and on the other side by FGF23 effect, left ventricular hypertrophy. Those elements will increase at the end the cardiovascular disease events. And in this long list of risk factors for cardiovascular disease, you can see that increased serum phosphorus is one of the first and most common causes of increased prevalence of the vascular calcification, endothelial dysfunction, and the cardiovascular disease and mortality, with a lot of reference listed there. It's not only in chronic kidney disease patients, but it's also in general population. This diagram showed that increasing the serum phosphorus level will increase the adjusted hazard ratio for mortality after correction for more than 20 factors. So up to more than 4 milligrams per deciliter increase in the phosphorus level will increase the adjusted hazard ratio for mortality. So it's not only in CKD patient, but also in general population. The relationship between the phosphorus level, this is the famous U-shaped curve, denoting the relationship between the serum phosphorus level and the hazard ratio. So in severe hypophosphatemia, the hazard ratio are increased, and also in severe hyperphosphatemia, it is extremely increased. The relationship between hyperphosphatemia and bone disease is quite proved and clear, and we can see here as the GFR is decreased less than 20 milligrams per minute, the fraction of woven stoid bone are increased. There is a big inter-patient variation, but at the end it is significant. Also in different stages of kidney disease, you can see in stage 5 and 4 and 5, there is increased bone formation and decreased mineralization lag time, which denote that there is increased ratio of bone turnover. This famous graph showed that in CKD patient, it is not only the phosphorus who is a risky for increased ratio for all-cause mortality. And we can see here that as the phosphorus level increased up to 7, there is an increase in all-cause mortality. Also accompanied by increase in intact PTH. And the worst scenario comes when both are increased. In Cosmos study, which involved more than 6,700 patients, it is a randomized controlled trial for 3 years. They found increased the hazard ratio in severe hypophosphatemia and hyperphosphatemia, also in severe hypo and hypercalcemia. And they denoting that the magic numbers that we should target is phosphorus around 4.4 milligram per deciliter, calcium around 8.8 milligram per deciliter, and PTH around 400 picogram per ml. So when we start to diagnose our search for the hyperphosphatemia and bone mineral disease in chronic kidney disease patient, this recommendation, the last version for public review draft from August 2016 for the KDU guidelines. And I'm sure that you all are familiar with this table. So they recommend to start screening for hyperphosphatemia and marker for bone mineral disease at early as stage 3, and we should check for phosphorus and calcium every 6 to 12 months, starting from stage 3. And the frequency should be increased according to the progression of kidney disease. They recommend that bone biopsy, if it will should be taken if it will impact the treatment decision. And we should monitor the parathormone and alkaline phosphatase to evaluate bone disease. This is a class 2B recommendation. And bone mineral density shouldn't be done routinely and only if it will affect the treatment. They have a specific recommendation for infant to measure the length quarterly, every 3 months, and for a child to measure the length annually. One of the missed areas for investigation is how to diagnose the vascular calcification. They recommend to do lateral abdominal X-ray and echocardiogram for vascular and valvular calcification. And we can see that we can easily appreciate and touch the vascular calcification by doing simple lateral abdominal X-ray. And also the calcification of the valvular calcification by doing echocardiogram. Positive valvular and vascular calcification are considered as the highest cardiological risk. And they also confirmed that using this lateral abdominal X-ray is a reasonable alternative to computed tomography. It is a good accepted alternative to CT. So again, when to start, it should, in patient with CKD stage 3A up to 5D, treatment of CKD and bone mineral disease should be based on the serial assessment of phosphorus and calcium and BTH level. In a patient with CKD stage 3A to 5D, we suggest lowering elevated phosphorus level toward the normal range. And they only changed the term lowering instead of keeping. So they only recommend to start treatment for the patients with hyperphosphatemia, not treating patients with normal phosphorus level. The cornerstone for management of the, as considered before, for management of hyperphosphatemia is diet control. So should we restrict it? Should we restrict the diet? I love this title in this paper published in International, when the author said, serum phosphorus in people with chronic kidney disease, you are what you eat. So you can control your phosphorus level by controlling what you eat. As we all know, there is an increase in the dietary protein intake accompanied with increase in the phosphorus intake. So if we do restrict our phosphorus intake, it will be accompanied by negative protein balance. So we also all know that decreasing albumin level, decreasing protein intake, will increase the hazard ratio for all-cause mortality. So how to solve this problem? If we restrict phosphorus, we will involve the patient and it will be complicated by negative protein balance, which increase the hazard ratio for all-cause mortality. So what the solution for that? The last recommendation, we should start phosphorus restriction in diet as long as the GFR decreasing less than 30 milligram per minute. The only patient that will get benefits from this maneuver is patients with hyperphosphatemia. So we should not restrict phosphorus in CKD patients with normal phosphorus level. And the rationale for that is that dietary phosphorus is not highly linked to the phosphorus serum intake, and it's also associated with protein energy wasting, which is associated with increased mortality. There is a very nice study recently published in the Kenya International showed that there is no link between the dietary phosphorus and the progression for kidney disease. And this evidence comes from the post-hoc analysis for the MDRD study for about 800 patients. And they evaluated the total phosphorus intake by 24-hour urinary phosphorus collection, which is the main strength for this study. Another study, another review, concentrating on the balancing nutrition and serum phosphorus in maintenance dialysis. And they recommended to maintain the phosphorus level with normal range and assess current dietary habits and reduce the phosphorus intake. But we should revise with the patients which kind of food that we should restrict. In non-hemodialysis CKD patients, as we can see, as serum albumin comes lower, as serum albumin comes lower, the hazard ratio for mortality again increases. And this is for non-hemodialysis CKD patients. So we should concentrate in this pyramid, which is called the phosphorus pyramid. We need to make the patient careful about the type of food. So if the patient restricted the food in red, which have a very high ratio, phosphorus to protein ratio, it will not affect the total protein intake, and it will affect significantly the total phosphorus intake. So all those foods in the base of the pyramids are accepted, and we should restrict all foods at the top of the pyramids. Also, I have to ensure that to make the patient aware about the boiling effect of increasing the phosphorus level in the cooked food. The same recommendation about the blood control in stage 5D disease patients. Lower elevated phosphorus level toward the normal range, and we should maintain an optimal protein intake of 1.1 gram per kilogram per day. We should ensure that the patient is aware about the phosphorus content of different foods, and we suggest limiting intake of processed food and drinks which have high phosphorus contents, and we should emphasize in maintaining adequate protein intake. Again, the same curve, but here the relation is more clear. As the serum albumin concentration increased, the hazards for this is decreased. And you can see the difference between 3.4 gram per deciliter of albumin increase. If it is decreased to 3.2, the hazard ratio will increase for 1.4. So what about the phosphate binders in CKD? This table showed when we should start the phosphate binder in different stages with CKD. In a patient with CKD stage 3A to 5D, we suggest lowering elevated phosphorus level towards the normal level, and we suggest avoiding hypercalcemia. In children with CKD stage 3A to 5D, we suggest maintaining serum calcium with the age appropriate normal range. The next recommendation in patients with stage CKD 3A to 5D, decision about phosphorus lowering treatment should be based on progressively or persistently elevated serum phosphorus. So again, the difference between the current recommendation and the last recommendation, that they recommending treating the patients with progressively increased or persistently increased phosphorus level, and not to start treating hyperphosphatemia in patients with CKD if the patient have normal phosphorus level. In the patient with stage 3A to 5 who are not dialyzed, we should consider phosphate binder prescription and evaluate appropriate phosphate binder. Discuss with the patient's beliefs and concerns about the medication to optimize adherence. Discuss the possibility of self-adjusting phosphate binder dose. For patients with hemodialysis, we should do the same, and we should optimize the prescribed calcium-based phosphate binders if the patient has hypercalcemia or consistently low pH. So we have two different types, groups of phosphate binder, the calcium-based phosphate binder and non-calcium-based phosphate binder. The calcium-based phosphate binder consists of calcium carbonate or calcium acetate, and we have a different types of non-calcium-based phosphate binder, starting with sevelamer, hydrochloride or carbonate, and lanthanum carbonate, and the newly used saccharophilic oxyhydroxide. To appreciate how it is difficult to maintain the total pills per day for the patient, this is the picture showed different types and shapes of phosphate, calcium-based and non-calcium-based phosphate binder. And we should remember that the limit and the number of pills for sevelamer carbonate per day may reach about up to 10 pills per day. And for lanthanum, the maximum dose is like 8 to 9 pills per day. So, to compare between different historical and currently used phosphate binder, we'll start with aluminum-containing acids. And its advantage is that it is effective, easy to administrate, and it is very cheap. But have a lot of disadvantages like aluminum toxicity, limited time of use, and limited dose, needs to frequent monitoring of aluminum level, and for that it is no longer recommended. The calcium-based binders, the advantage of calcium-based binder is that it is effective in about 60% of hemodialysis patients, and it is quite cheap. But the serious disadvantages is hypercalcemia, vascular calcification, calciphylaxis, which potentiate and it can potentiate the aluminum toxicity with large unpalatable tablets. The first member of non-calcium-based phosphate binder is sevelamer. Its advantage is it is effective. There is no fear of hypercalcemia, no risk factor for calciphylaxis and vascular calcification, and it has another effect as it reduces the low-density lipoprotein cholesterol. The disadvantage of sevelamer, either hydrochloride or carbonate, is it is expensive, actually expensive, with large bill burden. As I told you, it may reach up to 10 tablets per day. Its main side effect is GIT disturbances and binds soluble vitamins. The second member of non-calcium-based phosphate binder is lanthanum carbonate. Its advantage is that it is effective, not affected by the pH level. It can be chewable, it is chewable tablets, and its disadvantage is still expensive, like sevelamer, carbonate, and hydrochloride, and have some GIT disturbances with minimal absorption from GIT. So at the end, the guidelines did not recommend specific binder dose, but in KDIGO 2016, they only recommend restriction of calcium-based phosphate binder in hypercalcemia and evidence if there is evidence of vascular calcification. NICE guidelines 2013, the last version, recommended start with calcium-based and shift to combine with sevelamer if not tolerated or hypercalcemia detected. But I'd like to show two recent meta-analyses that I believe that they may affect the forthcoming guidelines. The first big meta-analysis done by Suvi Jamal and was published in Lancet 2013. It's concentrated on 21 randomized controlled trials composed of more than 4,500 patients, and it showed 22% reduction in mortality with non-calcium-based treatment. And the interpretation of the results stated that non-calcium-based phosphate binders are associated with a decreased risk in all-cause mortality compared with calcium-based phosphate binders in patients with chronic kidney disease. But they commented that further studies are needed to identify causes of mortality and to assess whether mortality differs by type of non-calcium-based phosphate binders. It means comparing between the sevelamer hydrochloride and carbonate and lanthanum carbonate. Another meta-analysis recently published in CJS in 2016, they concluded that patients with CKD stage 3 to 5D using sevelamer had lower all-cause mortality compared with those using calcium-based phosphate binders. But again, because of the lack of placebo-controlled studies, question remains regarding phosphate binders benefits for patients with CKD stage 3 to 5 and not in hemodialysis. The last meta-analysis published in PLOS 1 2016 also, and it analyzed 28 randomized controlled trials for more than 5,000 patients. and they compare different kind of calcium phosphate binders. And for the part comparing the calcium-based and sevelamer, as you can see, all the results were inside the sevelamer. And when they also separately compared the lanthanum carbonate with calcium-based phosphate binders, most of the results were significant on the side of the lanthanum carbonate. So I believe those three meta-analyses may impact the recommendation for the next guidelines. And then, I'm sorry about this title, this is calcium-based, this is non-calcium based. So the way and the evidence recently towards the calcium, the non-calcium based, because of the, I'm sorry about this title, because of the seriousness and the dangerous vascular calcification that can be issued with hypercalcemia detected in calcium-based phosphate binders. So if we want to choose between sevelamer and lanthanum carbonate, there is a recently done also randomized crossover study trying to find which one is best of those non-calcium based, and actually at the end they didn't find significant difference on the effect, but they found a difference in the side effects profile. So the constipation were significantly more with sevelamer hydrochloride compared to lanthanum carbonate, with some other GIT problems were more with lanthanum carbonate. So we can say at the beginning that both lanthanum carbohydrate or sevelamer are equal. But we can enumerate some advantages and disadvantages of both. So what we see with lanthanum carbonate is it is of slightly lower cost, it has some anti-hyperkalemic effect and low bill burden relatively to compared to sevelamer. On the other side, sevelamer have higher phosphorus control, proved long-term safety because it was discovered more than 10 years ago, and lower GI symptoms, especially reflux and carbon monoxide production, specific higher LDL control. But at the end, there is no sharp demarcation between both. So we can say freely that lanthanum carbohydrate and sevelamer hydrochloride or carbonate are equal on effect. Recently, there is an FDA-approved treatment for hyperphosphatemia based on iron, saccharophilic oxyhydroxide. It is a polynuclear iron-based phosphate binder. Phase 3 studies against sevelamer showed equal efficacy in hemodialysis and the peritoneal dialysis patient. It also has some GIT side effects as it darkens the stools, and it may mask the GI bleeding, which is found to be quite serious. And there is some ongoing phase 4 trials to prove its efficacy in comparison with different phosphate binders. Other management for hyperphosphatemia that we should check and control: vitamin D and CKD, stage 3A to 5. The optimal PTH is still not known, but we should treat it if it is progressively rising and evaluate the modifiable factors as hyperphosphatemia, hypocalcemia, diet and vitamin D deficiency. Calcitriol and vitamin D analogs need to be routinely used only if the in stage CKD 4 to 5 with severe hyperparathyroidism, they may be considered non-children. In patients with 5D on hemodialysis, if requiring PTH lowering therapy, calcium-immediate calcitriol, vitamin D analogs or combination are suggested. So I'd like to end up by a couple of slides about the future of treatment for hyperphosphatemia. So there is a recently published research about the nicotinamide used in decreasing absorption of the phosphorus, and we can see here that the phosphorus can be absorbed through the intestine through two different ways: intracellular and transcellular, which is controlled by sodium phosphorus 2B cotransporter, and nicotinamide is not known to close or block this pathway. There is recent Few research is concentrating on the usage of nicotinamide in phosphate homeostasis in chronic kidney disease patient, and these 6 trials just recently published and highlighted some different doses in using this agent in controlling hyperphosphatemia, and their comments about the percentage and the incidence of some side effects for the using this drug, like hypercalcemia, flushing, and diarrhea, which is the most common side effects detected with this agent. There is some other drugs under investigation, like the combined phosphorus binder, calcium acetate, magnesium carbonate, and cholesterol, which is like resin binding the phosphorus inside the intestine so it will not be absorbed. In conclusion, I'd like to summarize that hyperphosphatemia is inevitable complication of chronic kidney disease due to phosphorus retention. Hyperphosphatemia is associated with increased cardiovascular risk and vascular complication, causing poor outcome in CKD and hemodialysis patients. Lines of hyperphosphatemia treatment are controlled CKD progression, diet control, phosphate binder, controlled BTH and vitamin D levels. Strict diet control is not indicated, and we should emphasize on keeping positive nutritional status. Treat CKD patients not in dialysis and hyperphosphatemia or progressive hyperparathyroidism are detected. Non-calcium-based phosphate binders are favorable over the calcium-based ones when available, and linked with decreased all-cause mortality. Hyperglycemia is an indication to shift to non-calcium-based therapy. No clear demarcation favors any of non-calcium-based phosphate binders, but long-term safety and of severe is well proved. Iron-based phosphate binders is currently in use, and no large studies above its superiority now. Thank you.
Thank you very much, Dr. Ahmed, for this comprehensive, updated information about phosphorus and how to control. And I think it will open many questions. And I have my comments at the end. So let's start with your questions, please.
Merci beaucoup, professeur. Les troubles phosphocalciques sont vraiment d'un très grand intérêt et moi je me porte particulièrement par rapport à ça. C'est pour ça que je vous dis vraiment merci pour cet update qui vraiment fait le point de tout ça. J'ai quand même 2 petites questions. La première, vous avez si bien montré la relation qui existe entre l'hyperphosphatémie et les risques cardiovasculaires, la progression de la maladie rénale chronique, la mortalité et tout ça. Et en même temps, dans votre travail, vous nous avez montré que le risque entre, enfin le lien, pas le risque, le lien entre l'hyperphosphatémie et le FGF23. Alors, le FGF23 qu'on connaît, on sait aussi qu'il monte beaucoup plus tôt au stade 1, au stade 2 de la maladie rénale chronique, alors que l'hyperphosphatémie apparaît bien plus tard au stade 3A, 3B de la maladie rénale. Cet FGF23 est connu par son effet sur l'hyperphosphatémie, parce qu'on sait que le FGF23, ne serait-ce qu'en dehors du fait qu'il y a la maladie rénale et que l'excrétion du phosphore sera diminuée, mais le FGF23 a une action directe sur le tube digestif, sur la réabsorption et sur les parathormones, les parathyroïdes, etc. Donc cet effet systémique fait qu'on sait on s'attend à une augmentation forcée de l'hyperphosphatémie.
This is a first short question.
Maintenant,
let Dr. Ahmed to answer this question, and the next one will be after.
Yes, I haven't finished my
question.
Maintenant, je veux juste savoir, selon vous, est-ce que vous ne pensez pas qu'on pourrait être amené à traiter l'hyperphosphatémie déjà beaucoup plus tôt avant même qu'il n'apparaisse? Ça, c'est la première question. Après, je vais parler de la deuxième.
So the first for this question, for the first question, if I can try it. So there is a recommendation that following up clinically or practical following up of FGF23 is not that beneficial. So surveying or detecting FGF23, as I showed it in my slide, that it is elevated. It is the first thing to be elevated, and it is first thing to get out of normal range. Okay, but the recommendation is not to follow up FGF23 regularly or to detect it early. There is no recommendation for that. That is the first thing. Also, I know that FGF23 have a lot of its biological, it is pleiotropic effect, and I showed some slides about its effect on the vascular endothelium, its effect on the cardiomyopathy and the hypertrophy, left ventricular hypertrophy. But if I got it right, you are asking if there is an indication for early survey and detection for FGF23. There is no recommendation for that.
Not the early survey of FGF23, but the early treatment of management of hyperphosphatemia.
Okay, let me just have a comment. First of all, FGF23 is phosphatoric. So in the early beginning of chronic kidney disease, FGF23 even becomes higher before the evolving hyperphosphatemia.